Hi, my name is Dr. Robert Kaufmann, and we're about to go beyond the terminus. Where do you end your endodontic filling? The question has been asked for many decades. In the past, extrusion of any sort of filling material past the apex of the tooth was considered unacceptable by many clinicians, especially those in Europe. Conversely, advocates of the warm gutta-percha technique routinely would find sealer puffs extruded through the portals of exit. They considered these to be an acceptable part of obtaining apical patency and a logical sequela to trying to deal with a complex root canal system anatomy. Many years ago, when I was still a general dentist, the famous endodontist Dr. Frank WEINE came to my hometown of Winnipeg to lecture on endodontics. At that time, I had an interest in the specialty and I was considering applying for postgraduate position. He showed a diagram of the apex of the tooth and asked where the end of the canal was. I raised my hand and he got me up on stage. Technically, it was a trick question. No matter where I pointed to in the diagram, he always had an answer to indicate that this was not the end of the canal. Was it at the radiographic apex? Was it at the cemento-dentinal junction? How about the soft tissue right at the apex? Was this pulp or PDL? Did the canal end at the apical constriction? Was this supposed landmark even present in many teeth? And where was it exactly? Did the end of the canal end at the radiographic terminus, which was often outside the confines of the canal itself? And what about necrotic pulps? We know that in cases where there are periapical radiolucent findings and chronic apical inflammation, resorption of the apex frequently occurs. In that case, there rarely is an apical constriction. So where does the canal end in such cases? The truth is that if we're using 2D imaging, we're often wildly off in terms of the actual end of the canal itself. 3D imaging has helped us determine this, but the question remains, for routine endodontic treatment, where do we end the endodontic filling material? What is considered short and what's considered long? The philosophy for many clinicians is that it's better to have been there, that is being slightly long, than to have never been there and risk an unclean or untreated section of the canal system. If you're going to maintain patency and use a technique that involves the use of sealer, especially with the warm gutta-percha technique, you're invariably going to end up with sealer puffs at the end of the canal system where it enters the periodontal ligament. I've always found it interesting how some people are unhappy with the concept of tiny sealer puffs or slightly long-filled canals, many of which are resorbed by the body, while at the same time they have no hesitation in placing these gigantic titanium implants right into the bone. So, how do we get the best estimate of working length? In my office, we use a combination of several different techniques to be able to ascertain where a cone should be placed and where to expect my obturation to end. They include, firstly, the radiographic estimate of working length, which can include both conventional and 3D imaging. Secondly, tactile feel with the hand file. It's not perfect, but sometimes pretty accurate. Thirdly, the electronic apex locator. And fourthly, the Rosenberg paper point technique. To learn more about these techniques, check out my other Beyond the Terminus videos that deal specifically with obtaining working length. Remember, when we do the right thing, we both get better, patients and clinicians. I look forward to our next trip when we go beyond the terminus. See you then.